Today we are diving into a topic that keeps millions of people up at night with a painful burning sensation in the chest: acid reflux, clinically known as gastroesophageal reflux disease, or GERD. You might have experienced this yourself. You take your medication on time, you watch what you eat, yet that sour, burning sensation inevitably returns when you least expect it. Why does acid reflux keep recurring? Why does the thin lining of your esophagus feel like it's caught in a never-ending war? Today we're going to look at the latest evidence from the American medical community, including insights from the Mayo Clinic and the Cleveland Clinic. We will deconstruct this health mystery affecting hundreds of millions worldwide. And by the end of this video, I'll reveal a fatal mistake in treatment plans that most people completely overlook. To understand why reflux recurs, we first have to look at the door inside your body, the lower esophageal sphincter, or LES. In an ideal world, this muscle acts like a one-way valve. Once food passes through, it should snap shut, forming a tight seal against the powerful acids in your stomach. According to research from the American College of Gastroenterology, the core issue in recurring cases is a mechanical failure of this door. It's not just that the door is broken, it has lost its tension. When the pressure of the sphincter drops, or when it relaxes too frequently, the stomach's hydrochloric acid, pepsin, and even bile surge upward like a flood breaking through a levee. Many believe reflux happens because there is too much acid. However, American medical evidence suggests a more radical conclusion. For the vast majority of chronic patients, the problem isn't the amount of acid, but rather that the acid is in the wrong place. The esophageal lining has an extremely low tolerance for acid. Even a tiny leak triggers a massive inflammatory response. This chronic inflammation further damages the nerve feedback of the sphincter, creating a vicious cycle. That is why you feel like you can never truly pull the problem out by its roots. If the issue were just functional relaxation, medication might do the trick. But when physical structures change, recurrence becomes a certainty. This brings us to a critical concept: the hiatal hernia. In American diagnostic imaging, a significant portion of stubborn reflux patients actually have a hiatal hernia. Put simply, due to increased abdominal pressure, a portion of the stomach is pushed up through the opening in the diaphragm and into the chest cavity. This causes the valve to fail because the sphincter and diaphragm can no longer work together to maintain a seal. Why does this structural issue lead to constant recurrence? Because medication can only reduce the acidity of the stomach juice. It cannot move the stomach back to its proper place. As long as the structure isn't corrected, mechanical reflux will happen around the clock. This explains why many patients see their symptoms roar back within 2 or 3 days of stopping their acid blockers. Next, let's discuss a controversial point in treatment: proton pump inhibitors, or PPIs. The American medical community has observed an interesting phenomenon in long-term clinical studies. Patients who take high-dose PPIs for a long time often experience even more severe reflux when they try to quit. This is due to the body's self-regulatory mechanism. When you artificially suppress acid production for a long time, the acid-producing cells in the stomach enter a hyper-excited compensatory state. Once the drug is removed, the stomach pumps out acid at a much faster rate than normal. Many patients develop both a psychological and physiological dependency, believing they need the drug for the rest of their lives. In reality, this recurrence isn't always the disease getting worse. It's the body's acute stress response to stopping the medication. Without a professional tapering plan guided by a doctor, this rebound effect keeps you trapped in a cycle of medicate to feel better, quit to get worse. Why does reflux always seem to flare up at night? The American Academy of Sleep Medicine conducted a study showing that over 70% of reflux patients experience silent reflux during the night. When you lie flat, you lose the barrier provided by gravity. If your dinner contained high-fat foods or if you ate within 3 hours of bedtime, the stomach empties much slower. Because of the change in physical angle, acid can easily slide into the esophagus. Even worse, swallowing, and saliva production, the body's strongest natural weapons for neutralizing esophageal acid, decrease significantly during sleep. This microscopic nighttime reflux continuously burns the esophagus, leaving it in a highly sensitive state during the day, even if you avoid spicy foods. Therefore, if you don't change your sleeping position or adjust your meal timing, medication alone can never fully solve this physical problem. In American medical guidelines, lifestyle intervention is considered just as vital as medication. However, most people's understanding of dietary triggers is too narrow. Recurring reflux is often driven by high intra-abdominal pressure. Take, for example, central obesity, what we often call a beer belly. Excess visceral fat acts like an invisible pressure pump, constantly squeezing the stomach. Or consider chronic smoking. Nicotine directly lowers the pressure and tension of the lower esophageal sphincter. There are also overlooked dietary habits such as caffeine and alcohol consumption. These don't just stimulate acid. More importantly, they relax the muscle tone of the sphincter. Many patients take their anti-reflux meds while religiously drinking 3 or 4 cups of black coffee a day. This is like trying to build a dam while simultaneously opening the floodgates. For chronic recurring cases, American medical protocols have shifted from simple acid suppression to a more comprehensive approach of motility repair and structural intervention. First is motility testing. Doctors use esophageal manometry to precisely evaluate the pressure and peristaltic function of the sphincter. If the physical motility is the problem, acid suppression won't help much. Second are minimally invasive interventions, such as the increasingly popular Lynx reflux management system. This involves placing a small ring of magnetic titanium beads around the sphincter to help the valve close. It solves the reflux problem physically without interfering with normal swallowing. Furthermore, for severe hiatal hernias, American surgeons often recommend laparoscopic fundoplication. The goal of these methods is the same. Use physical intervention to end the false balance maintained by lifelong medication. Now let's reveal that critical point I mentioned at the beginning. Many patients with recurring reflux don't actually have too much acid. They have too little stomach acid or a deficiency in digestive enzymes. It sounds counterintuitive, right? But some functional medicine experts in the US point out that when stomach acid is too weak, the pyloric gate at the bottom of the stomach is slow to open. This causes food to sit in the stomach for too long, where it begins to ferment and produce gas. This gas carries a fine mist of acid upward, forcing open the sphincter and causing reflux. If you continue to take acid-suppressing drugs in this scenario, your stomach acid decreases further, digestion becomes even harder, and reflux becomes more frequent. This is why some people find that the more stomach medicine they take, the worse their condition becomes. To truly say goodbye to acid reflux, you need a systematic action plan, not just a prescription. First, get a high-definition endoscopy and a motility assessment to see if you have a hiatal hernia. Structural problems must be addressed with physical solutions. Second, strictly follow the 3-hour rule. No lying down for 3 hours after eating. Give your stomach time to empty. Third, elevate your upper body during sleep. Use gravity to protect your esophagus at night. Fourth, taper off medication scientifically. Under a doctor's supervision, move from daily doses to every other day to allow your stomach cells to adapt, avoiding the rebound effect. Fifth, focus on metabolic health. Losing belly fat isn't just about looks, it's about decompressing your stomach. Acid reflux is never just a localized problem. It is a warning from your body that the balance between structure, function, and lifestyle has been broken. The pain of chronic recurrence is a reminder that we cannot just stare at the acid, we have to fix the door. When you start to respect the physical logic of your body and rebuild your digestive environment from the source, that erupting volcano can finally be silenced. That's all for today's program. Has your acid reflux been a recurring struggle? Which trigger resonated most with you? Feel free to share your journey in the comments so we can explore the path to recovery together. Thanks for watching. I'll see you in the next one.